Hello, everyone. Thank you all for joining us today. My name is Izumi Nakano, and I am the Associate Director of Support Services here at the Lymphoma Research Foundation. I'm honored to introduce Dr. Danielle Brander, who will be speaking on the topic of chronic lymphocytic leukemia, small lymphocytic lymphoma. Dr. Brander is an Assistant Professor of Medicine at Duke Cancer Institute. We are proud to count her as an LRF grantee and a former LRF scholar. After Dr. Brander's presentation, we'll have plenty of time for questions. At the bottom of your screen, you will see a Q&A button. Please submit your question at any point in this box. I'll now turn the talk over to Dr. Brander.
Thank you. It's really truly an honor to be here presenting with this group and with working with the LRF, which holds definitely a special place in my heart, given all the patient and caregiver education, but also truly the support provided to those completing their medical training and deciding to focus in a career in leukemia, chronic lymphocytic leukemia and lymphoma. So thank you. We have a lot to cover today, and I'll try to make this broadly applicable depending on where you are in your journey of being newly diagnosed to perhaps living with CLL for a number of months or years now. So I recognize not all of this will pertain to you, and some will be more technical in talking about trials, but I think it's helpful to go over that information, and we'll have time at the end so we can answer questions. I'll also highlight, as you've probably seen from the agenda, that I'm fortunate that during this talk, I'll focus more on introduction and the frontline or first treatment options for patients with CLL. Later during this conference, there will be separate sessions talking specific topics such as minimal residual disease, as well as treatments for patients that have had treatment before or have relapsed or refractory CLL. There should also be provided my disclosures. I include them here, including a number of grants that we participate, as well as some consultings, and I'm a member of the NCCN CLL and hairy cell leukemia panels. So we'll get going in the background. One of, I think, if you're early on in this journey, confusing thing is whether we call CLL a leukemia or whether we call it a lymphoma. And the name, of course, is chronic lymphocytic leukemia, which really refers historically to the term of elevated white count or being in the blood. But as we'll talk about biologically or how the cells behave, they share a lot of treatment and characteristics with B-cell lymphomas, and hence it's also a non-Hodgkin B-cell lymphoma. When you look at the different leukemias, though, CLL is the most common leukemia in Western countries. Now, on incidence or cases per year, it nearly matches acute leukemia, but fortunately, because more patients are able to live longer lifetimes, it is the most prevalent leukemia in the United States. Moving on, as I talked about, to thinking about it as a lymphoma, however, if you've had friends or family or heard of others with non-Hodgkin lymphoma, Hodgkin lymphoma or Hodgkin's disease refers to a specific types, although there's about 4 or 5 different types of Hodgkin's, and all the rest are classified as non-Hodgkin lymphoma. And since our body has 2 different types of lymphocytes, mainly B cells and T cells, most of the time we refer to non-Hodgkin lymphoma as the kind of cell that it probably came from before it became a cancer or a lymphoma. And the majority of them are B cell. Within it, there's over 50, 60 or more different types of B cell non-Hodgkin lymphoma. So just very simply, I think it's helpful, and I do this as I teach those in medicine and training to focus in oncology, that it's helpful to think of B-cell lymphomas as those that are more indolent or slower growing, and those are more aggressive or highly aggressive. And having this framework and understanding that CLL or SLL falls into that indolent group, along with other types such as follicular, marginal zone, or lymphoplasmacytic, helps to understand how we approach in making our recommendations, but also some of the treatments, especially the what we call targeted treatments, are shared amongst those with shared disease features. Now, one of the things about indolent lymphomas is they all share that many times patients don't need treatment around the time of diagnosis. they might progress to needing therapy. But the other characteristic is while they're treatable, we generally think of the indolence as not curable, whereas the aggressive or highly aggressive, if you've heard of patients with this, they need treatment right away. And while they can be cured, if the disease is the lymphoma very aggressive, unfortunately, also might need multiple treatments to try to get a response. And this is just the background information. Want to highlight, we already talked about the comment about 20,000 new patients are diagnosed per year, but we think over 130,000 people in the US are living with CLL or SLL. And while generally it is diagnosed later in life, median age around 70, certainly we see patients as early as their 20s, though not as common, 50s and 60s, much more common that we see too, as well as patients diagnosed in later life. And then the diagnosis now can be made usually from the blood. Sometimes if you're noted to have a large lymph node, you might have a biopsy that leads to the diagnosis, or occasionally the blood counts are very low and your white count's not high, so you might have a bone marrow biopsy. But by and large these days, most patients can be diagnosed from a blood test called flow cytometry. And what that does is your team sends your blood sample and they mix in all these basically antibodies and stains and then run it through a special machine. And then the computer program of the machine can interpret the different markers on the outside of the cell. And that helps clarify that it's not a typical cell. So, and then from there can fit a pattern most consistent with CLL or SLL. But it usually does require other testing, such as something called FISH, which stands for fluorescent in situ hybridization, to distinguish CLL from another common lymphoma or another similar lymphoma called mantle cell lymphoma. There are a variety of spectrum of how patients may present when you're diagnosed. At one end of the spectrum, classic CLL or the leukemia part would be no enlarged lymph nodes, and a high white blood count, maybe low other blood cells such as the hemoglobin and platelets. Small lymphocytic lymphoma at the other end of the spectrum where the white count's not elevated, it's just the lymph nodes or spleen. But at the heart of it is the same cell type. And most patients will have a little bit of both, meaning the white count's elevated, but they also have enlarged lymph nodes or an enlarged spleen or low blood count. And so it really is a spectrum with most patients following somewhere along that line, and may progress over time to involve one or the other. But the point of it, if you hear CLL or SLL, the reason we usually combine it when talking about it is because if you only pulled out one abnormal cell from someone truly with SLL versus CLL, they look the same. And so we make our recommendations the same. Of patients diagnosed, there's what I say about the rule of thirds. About a third of patients or a little less need treatment in the first couple of months after starting their diagnosis. A third of patients, 25 to 30%, never need treatment. And this isn't just patients that are diagnosed with a lot of other health problems, or maybe diagnosed when they're 88 or 90 years old. There truly are patients in our clinic that we follow for many years and many decades. And while there are important other things we look out for, they may never need the CLL treated itself. But about 70 to 75% of patients eventually need treatment somewhere. And hence, I think the reason to understand what the options are. Now, if you are in that group and you have a new diagnosis, and it is, I have to say, even for those that do this a while, sometimes hard to wrap your head around why would you be diagnosed with a cancer or leukemia or lymphoma and not be treated? Well, part is that fact I just mentioned, that a third of patients never need treatment. So if we treated everyone when they were diagnosed, that means 20 to 30% of people that are exposed to treatment that never would need it. But importantly, there have been a lot of clinical trials over the years that have looked at patients being treated at the time of diagnosis versus not until they meet specific indications, which we call the IWCLL reasons, and I'll talk about that in a minute. Those studies have largely been done with chemotherapy. Some studies have now been done with treatment with ibrutinib. And I also want to highlight, though, that we've started to think about it differently. Instead of doing trials that treat everyone, maybe identify patients most likely to eventually need treatment by their markers, and look at trials that use the novel drugs, less side effects, maybe better responses in patients very likely to need treatment. So I don't want to think that it's left that we're just going to accept that no patient should ever be treated at the time of diagnosis if they don't meet indications. Those trials are ongoing and very important, and we're grateful for patients that participate. Very briefly, there's something called the IWCLL, or the International Working Group of CLL. It's a group of international investigators, and about every 10 years, there's a set of guidelines to help clinicians caring for patients with CLL know what are the important things at diagnosis, what are the things to look for treatment, and specific other special topics. So I tell patients, though, you can look at a list of reasons for treatment. I think of it broadly in three main categories: symptoms that are progressive and not manageable, the so-called B symptoms, like unintentional weight loss, feeling full, fast, or night sweats that are interrupting enough with sleep that you can't function the next day. Low other blood counts, so hemoglobin consistently less than 11 or platelets less than 100 for not other reasons, or lymph nodes, spleen enlargement, or rapid white count rise. Again, that's confirmed and meeting a certain size or causing problems. Now, it's beyond the scope of this to go over all the markers. We call them prognostic or predictive markers. These are characteristics that might help your clinician know more details about your CLL. If there are 130,000 people living with CLL, we know it's very heterogeneous or very different person to person and needing therapy. And so some of the key markers that have been identified are a test called FISH, which I mentioned earlier, that also helps distinguish from other types of lymphomas, and also can create this so-called hierarchy that would indicate whether patients are more likely to need treatment and respond to classic type. So there's the different hierarchy of favorable versus unfavorable. But these studies were done around the 90s, around 2000. So you can't really pull up the original studies and say it pertains to treatments today. But as I'll highlight moving forward, there are many important parts: IGHV mutation status, and then just want to highlight that TP53 protein can be mutated, and that's unfavorable. This is purposefully one too many way too many figures for one slide. Just want to highlight again, there's a classic staging system for CLL, SLL called the RISE staging. Over the years, you'll see in the colorful figure kind of in the middle right, looking at FISH and how patients do. But again, these studies done at the bottom, you'll see their references anywhere from the 60s, 70s to the 90s. And so we're always looking for new ways and how the markers pertain to today's world and today's treatment. One of it is called the CLL IPI score. And while it too doesn't include patients treated with all the novel agents, it might incorporate FISH, IGHV, and some other clinical factors instead of just one marker, and might be a good tool to build on to identify patients likely to need treatment and maybe change or shift how we do the treatments. So again, purposely a slide with a lot of data, but I like leading with this both when I talk with patients as well as when I talk with other healthcare professionals that help care for CLL treatments, because to understand where we are, we're indebted to patients and caregivers that have participated in trials along the way. And while 60 years or 30 years might sound like a long time, in the speed of development of treatment for CLL, we really have come a long way, though we still have work to do to optimize treatment for all of our patients. But what CR and ORR, that means complete response, meaning kind of the best classic response you can get, overall response being any response to treatment. And so to just highlight some of these agents historically, with some of the chemoimmunotherapy that gave those higher response rates, the majority of patients, either because of their age or other medical factors, couldn't get that intensive chemo. Even younger patients that could had a lot of side effects during and after treatment and risk for other bone marrow damage. Where we are today, starting in the 2010, more like 2013, 2014, started to have approval of what we call the targeted agents that target either the way the cell takes things from the outside and signals inside, so-called, to kind of feed the cell and keep it alive, or BCL2 inhibitors that controls what's called apoptosis. Most of the cells in our body, not all of them, our brain cells and certain memory cells don't die, but a lot of our cells do. Our skin cells, a lot of our blood cells depend on this programmed, controlled way of the cell living, doing its job, dying, and new ones being formed. And in some CLL cells, there's way too much accumulation or buildup, and Venetoclax or the BCL2 inhibitors go after that balance. So just a lot of progress. And again, just another special thanks to all those you may know or those on this call itself that have participated in the trial. And just another way to organize what's in the black are the approved drugs, so BTK inhibitors, ibrutinib and acalabrutinib, a bunch of other covalent binding. These affect the signaling in the cell. BCL2, I mentioned, Venetoclax or others being studied. And then of the BTK inhibitors, not so much for first treatment, so I won't go into it, but for those joining the session for patients previously treated, you'll hear about some of the other medications such as ARQ-531 or LOXO-305. These are non-covalent, so work different than the first ibrutinib, acalabrutinib, and zanubrutinib that bind to that target and don't let go. And these newer non-covalent inhibitors, because they bind to a different place in the target, may still work even if patients' leukemia becomes resistant to the first ones. Anti-CD20 antibodies, historically in the 90s and 2000, rituximab, which the antibody goes to the outside of the cell to a marker called CD20, which is on CLL cells, but also other B-cell lymphoma cells, drastically changed survival, but there are ways and new antibodies that are looking to strengthen that response. So if I just mentioned all these ways of improvement, why do we still need these trials? Again, I think in my clinic, I help care for majority of patients with CLL or SLL or other slower growing lymphomas. And from seeing patients where we've made tremendous progress for a lot of patients, there's still a lot of unanswered questions, for treatments that are given continuously, but patients do well with them. How do we know how to be able to stop them, maybe in combining? For young patients that have those markers that make the CLL behave more aggressively, how do we not lose sight of the fact that our goal is to help patients live life to their fullest, both from a side effect, but also from getting their CLL hopefully under control, that they can ideally live the length of life that they would have lived without this diagnosis. So I think there's still a lot of questions that we can do. I know that LRF provides great information on the type of trials. I saw there was an earlier wonderful session going over that, as well as they have great support staff for those looking to understand how you might participate in clinical trials. And again, just I'll highlight them moving forward. So one thing I just want to highlight, the IGHV mutation status, which is an adverse marker if it's unmutated historically, meaning back in the 90s when we first recognized the marker of unmutated IGHV, patients with unmutated versus mutated IGHV had about a 9-year shorter survival. But again, that was in the 90s. And as I'll show a slide with the targeted agents, that difference almost goes away. So a lot of importance versus classical chemotherapy, but also means if for some reason you are considering chemoimmunotherapy, it's really important to know this marker. But the second thing that I'll just highlight, in addition to the high risk by FISH, the deletion 17p, TP53 is the protein made by the part of the chromosome called 17p. So when 17p is deleted, you can't make the protein because you don't have the blueprint. If there's a mutation in it, you can't make it because the blueprint you're given is faulty. And about 10% of patients at first treatment have this marker. And if you look at old studies of 17p or TP53 with chemotherapy, response rates were very low, even with the intensive chemotherapy. But with the targeted agents, for example, on the left side with ibrutinib, a follow-up study, 85% of patients on frontline or first treatment BTK inhibitors still had a response, even with that highest risk marker. And then on the right, that unmutated IGHV, what you'll see in the orange lines at the top, if you saw in the introduction to trials, often we follow with time how many patients still have their CLL or disease under control. So as the line drops, that means less patients. But the two different orange lines are mutated and unmutated treated with the new drugs, versus the blue lines on the bottom are the difference of mutated and unmutated IGHV if treated with chemotherapy. So again, just highlighting it's important to look for these markers, but what they actually mean in a good way has changed a lot with the newer drugs. This slide is just summarizing that to date, if you look at registry studies, the testing though for these common markers such as FISH or IGHV is still pretty low across the United States. The FISH test done in less than 2/3 of patients, in the IGHV, less than 10% of patients. So let's talk about the BTK inhibitors. I want to mention two studies that looked at ibrutinib, which is a pill taken once a day, that it targets this protein called BTK inside the cell. And in two different studies a couple of years ago, the ibrutinib was compared to chemotherapy. On the left, it was for older patients, so chemotherapy for them versus ibrutinib rituximab. And on the right is the study that compared ibrutinib rituximab to the very intense chemoimmunotherapy for younger patients. But the takeaway was that the targeted drug as a first treatment, the ibrutinib, was better than even the intensive chemotherapy, not just in how long the CLL stayed in response, but now with a couple-year follow-up, also in survival of patients. And this has been some of the first studies demonstrating the benefit of this. However, with ibrutinib as the first generation BTK inhibitor, what you'll see is some of the common side effects. Atrial fibrillation is an abnormal beating of the heart. HTN, that stands for hypertension, bleeding, infections. And so what I want to highlight, the Alliance study was for patients age 65 or older. The ECOG column is for patients less than 70. And so probably not surprisingly, even with the novel targeted medicines, there are more side effects for older patients versus younger patients. But also the number of people that had to stop the treatment was much higher for older patients. And other studies have shown in outside of clinical trials that these discontinuation rates can be a quarter or more of patients. So again, continuous treatment, have to look for novel medicines. The Elevate TN is a next generation, also though, covalent BTK inhibitor called acalabrutinib, which is now approved for patients with CLL and felt to be more selective than ibrutinib, meaning we talk about what it's supposed to target, these medicines like BTK, but often they hit other unintentionally hit other targets. And so this was patients that never had treatment, over 500 patients, and they were split into thirds. A third got standard chemotherapy, that's the chlorambucil obinutuzumab antibody. A third got obinutuzumab antibody with acalabrutinib, and about a third got just acalabrutinib, the next generation BTK inhibitor alone. And so a central group of people assessed the response, and now there's about 4 years or 48 months of follow-up. And for those that got the chemotherapy, that middle box there, the G-chlorambucil, only about a quarter of patients 4 years after treatment haven't had their CLL progress, whereas with the acalabrutinib, it was 80% or more. So again, even the next generation better than chemotherapy as first treatment. But the other thing, looking at this, at least within the trials, is that there seemed AE means adverse event, PD means progressive disease. And so the acalabrutinib, there was just a little over 10% of people that stopped it due to a side effect, relatively low due to their CLL progressing. So potentially from this study, we learned about being more tolerable. In the talk for those able to join for talking about treatment of CLL that has relapsed, there's actually been 2 really important studies comparing directly for people that had treatment before. Half of the group got ibrutinib, half got acala in one study, and in another study, half got ibrutinib and half got zanubrutinib. And in both those studies, looks like the newer inhibitors potentially have less side effects. I won't go into detail about this, looking at response rate and minimal residual disease, because there's also a separate talk talking about different responses, but I do just want to highlight minimal residual disease I think of as a level beyond what our classic complete response was, because minimal residual disease, by whatever method is used, there's a couple of different types, looks at how much CLL is left at a very sensitive level. So at minimum, hundreds of thousands of cells are looked at either in the blood or the bone marrow to look if you can detect anything. And over time, this might become, for some patients, a benchmark. And this just highlighting with the antibody, you see more of it. So I want to move on from the BTK inhibitors and talk about an important frontline study using that other medication I mentioned, Venetoclax. So Venetoclax tips the cells from that building up too much and not dying off like the way they should to apoptosis by targeting this apoptosis protein called, or this anti-apoptosis protein called BCL2. And in doing that, the cells can almost like flip a switch from, at least some of them, from living too much to dying quickly. And because of that, Venetoclax, when it was developed in clinical trials, in addition to noticing great response rates, it was noted some patients have a syndrome called tumor lysis. Not unique to CLL, it's not unique to Venetoclax. In fact, for some of those aggressive lymphomas we mentioned earlier, some patients can have it with a variety of treatments. But when you see that, it requires close monitoring. And with Venetoclax, it led to the understanding that rather than starting patients at the full dose of the medicine, there's this so-called dose ramp up. And I'll have a next slide talking about that. But basically, this you weekly go up on the dose. And the frontline treatment, meaning as first treatment, we actually, for the first couple of weeks, start the antibody infusion treatment, so obinutuzumab, and don't start the Venetoclax till a couple of weeks in. And that also has helped a lot with the tumor lysis because the white count's usually much better before the Venetoclax is started and the lymph nodes start to get smaller too. So how we classify tumor lysis risk, and for those treated with Venetoclax or considering it, your care team will go over this in detail. The low versus medium versus high risk for tumor lysis is based on lymph node size and white count, as well as kidney function and some other factors. And many times as the first treatment, because the antibody brings down the levels, patients can do this escalation outpatient by coming in every week, 2 days in a row, usually to measure levels after good hydration or IV hydration, although occasionally we have patients that have to be monitored in the hospital. But looking at Venetoclax in the so-called what's been termed real world or outside of clinical trials, I want to highlight some of the side effects. So we mentioned looking at some of the common side effects of BTK inhibitors earlier of special interest with Venetoclax. In addition to tumor lysis, about half of patients can have low neutrophils, grade 3 or 4, called neutropenia, or other blood counts. And so sometimes your team will use growth factor support, and you'll see in the chart on the left, that's from the clinical trial about neutropenia happening in about 50% of patients. But febrile neutropenia, or fevers with neutrophils, which ultimately is what we're concerned about, was only about 5% of patients, likely because you can, your team can advise you on holding the medicine or giving this growth factor support. But in the study at the right, I just want to highlight, again, in the setting of looking outside of trials, it recognized too that another important factor of looking at tumor lysis risk is the kidney function. Again, I will not go over all of this because there's a separate session on minimal residual disease. Just recognize there are different ways to detect for low levels of cells. And along the left too, I try to at least just visualize, if you think of how many cells very simplistically you had before treatment, and then the red bar is what's considered a historical threshold for completely responding. You might have a few left that are still complete response, but a few cells left. Now with MRD, you kind of move that bar for detection lower. And in some cases, you might find then the little bit of cells that are left, or sometimes there might be some left depending on your threshold for that cutoff. But it's less than that if there are fewer cells. And again, people will go into the advantages and disadvantages of either flow or different sequencing way to look for that minimal residual disease. But I want to highlight in the follow-up of the CLL, that frontline study I mentioned now, patients treated with Venetoclax and obinutuzumab, because of the MRD rates and the way it was studied, is unlike ibrutinib or acalabrutinib that's given continuously until patients have to stop due to side effects or not working anymore. With Venetoclax, as a first treatment, the antibody is given for 6 months and the Venetoclax for 6 months, and then another 6 months, or a total of 1 year. So this follow-up information of 4 years of follow-up of the study means 3 years of follow-up after patients have finished that first year. And the takeaway from that is that 3/4 of patients with Venetoclax fixed duration for 1 year in the study still did not have progression of their CLL 3 years off of treatment, versus less than a third of patients with the chemotherapy. But it was less, or it was more likely, which not surprising, for the CLL to come back if there were some high risk markers such as the TP53. And it was a little less, though still markedly better than in the days of chemotherapy for unmutated. And the overall survival for patients, not yet a difference, but this is between the chemotherapy, not a surprise as first treatment. And I just, without going into too many details, want to highlight that at the bottom bar, that no BCL2 mutations. I think this is important because in the study, BCL2, that target of Venetoclax, can be mutated in patients that have, in the relapsed or refractory setting, that become resistant to Venetoclax. So since this is a fixed duration or 1 year of treatment, I think it was really important to see in studies that by stopping the medicine at 1 year, not only were 3/4 of patients without it relapsing 4 years later, but no one had developed resistance to the medicines, which was, again, very helpful. So the thing that I also, though, want to move into now is talking about the two different groups of main targeted therapies that we talked about, the BTK inhibitors and the Venetoclax, is can they be combined into one treatment, and how does that affect both how the medicines are tolerated, as well as maybe make those responses even deeper. And so again, I'm making sure, I know this is a whirlwind, that we have time for questions at the end, but I appreciate someone asking, just to clarify before we move on here, what MRD is measuring. So it depends what study you're looking at, but when we're talking about the CLL or SLL studies, it's looking for minimal residual disease. So it's looking for the CLL abnormal cells. And since they're you can diagnose them by flow, there are flow methods where they run hundreds of thousands of cells from your blood and see if they can detect any leftover CLL cells. But that term MRD, minimal residual disease, is also looked at in other leukemias. So what it's measuring for and the way you measure for it is different in different leukemias or different diseases. In this case, we're referring either by flow or sequencing of trying to find leftover CLL cells. So it's looking at if you can detect at a sensitive level any leftover CLL cells, which we presume in many cases after treatment are there at either a very low level or a detectable level. So the rationale for combining these started with a couple first studies, including at MD Anderson, that looked at combining ibrutinib and venetoclax, and this study was recently published. And the way it was given is, first of all, it had to be patients with some of the high-risk markers, but they also started the ibrutinib first. As I mentioned with venetoclax and the tumor lysis risk, by starting the ibrutinib a couple cycles and then starting the venetoclax, most patients had lower risk for tumor lysis. And the undetectable rates in the bone marrow of minimal residual disease, the C in that top left box there means cycles. So after 12 months, over half of patients, again, these are patients with the highest risk markers that with chemotherapy would have been unexpected to have good, if any, response. So undetectable levels in the bone marrow of minimal residual disease. And at the end of 2 years, about 2/3 or 24 cycles, and then the best response, about 75% of people couldn't detect the CLL in the bone marrow. I should mention, depending on the types of treatments given, meaning antibodies, those infusions, sometimes you can test the blood for minimal residual disease in the CLL, but depending on what treatment or the timing of that, sometimes it's best the bone marrow. These are the side effects. I won't go through all of them, but in combining them, combining two different inhibitors, not surprisingly, some of the side effects, that any grade of side effects, were higher with the combination, including GI side effects like diarrhea or nausea. And so I think just highlights that not every patient, this regimen is not yet approved, but if it does become approved to combine them, I think not all patients are the best for it. There's another study, though, that has looked at the importance of minimal residual disease. This is called the Captivate study, and again, untreated patients. And there were two different parts. One was called MRD driven, meaning patients were randomized to get one treatment or another based on their MRD status. If it was confirmed, meaning they didn't have detectable, they were randomized to see if continuing treatment with ibrutinib versus a placebo was helpful. But again, just in the patients who otherwise didn't have this detected, or it wasn't confirmed and they were randomized to get ibrutinib by itself or ibrutinib plus rituximab. And 1 year after randomization, in patients with undetected MRD, undetectable disease after venetoclax and ibrutinib, there was no difference in ibrutinib versus the placebo. Again, this was only for the combination, and they had to have undetectable MRD, but suggests that MRD is a good endpoint, and more treatment after that may not make a big difference if you achieve that. But if patients at the end of that time didn't have undetectable, in other words, they were MRD positive, then they were randomized to get either more of the double treatment or ibrutinib alone. And not surprisingly, probably is that more of the combination therapy was likely to take MRD positive, MRD negative. The fixed duration part of the study, though, this was a different way of looking at it, is instead of checking for MRD, maybe like the ibrutinib or the venetoclax frontline study, what if patients get a fixed amount of treatment? And so again, patients in this study, same two treatments, ibrutinib and venetoclax, and the fixed duration was looking at a set number of cycles, of 12 cycles of the combination, and then follow up. And at the end of this study, basically here you'll see the best responses, even in high risk patients that got fixed duration, and in patients without deletion 17 P, the rates were even higher for those complete responses. So still looking at fixed duration as well, and you'll see in the peripheral blood versus the bone marrow, you can sometimes see higher undetectable MRD rates. So beyond the scope to go over all of these, but I want to just mention that there are a number of other phase 3 studies that are looking at novel combinations as first treatment in CLL, some of these combining the next generation inhibitors as well. And so these will all be important studies. We'll look for the results of those. And then, as I mentioned, in terms of the randomized studies for patients with previous treatment, we'll hear more about that in a later session. So why are clinical trials still encouraged? I think, again, we're moving into an era, fortunately, where we have a lot of options, but there are still some things we won't be able to talk about today, such as patients that have transformation of their CLL, for those that do get novel agents and still have progression or have intolerance. But I'll also mention near the end of this is how can we meet unmet needs by things maybe identifying for patients with CLL that may not be directly related to their CLL. And so we'll talk about some of those prevention measures. So in the last section, just want to highlight, again, I am fortunate to work with a team at clinic, including nurses, nurse practitioners, and clinical pharmacists. And I think that team-based approach is really helpful, particularly as patients are starting and on treatment, so that you have a point of contact to know what to expect on treatment and also who to reach out to for questions moving forward. So these are some general principles, but your case might be unique. And so I encourage you to discuss specifics with your health team. Namely, since the targeted agents such as ibrutinib or acalabrutinib plus venetoclax are not approved, most of the discussions are about what agent to choose as frontline by itself. How do you try to lower the risk of certain side effects? And then if you do run into side effects, do you switch within similar inhibitors, such as, for example, ibrutinib to acalabrutinib, or is it better to switch to something completely different and the long-term side effects? So this past year, for some of the side effects of BTK inhibitors, we mentioned some of them, 10 to 15% of patients can develop atrial fibrillation, GI side effects. With time, high blood pressure, muscle and joint aches is one of the other common side effects that can lead to stopping the medicine. And other important ones, I think, are low, though not as common, low blood count, some other arrhythmias, rashes. Mentioned before, easy bruising is common in about half of patients, but of course, how do we lower the risk of severe bleeding? So the atrial fibrillation, I just want to highlight this funny beating of the top part of the heart is not, it certainly happens either under stressors or by chance, and it increases with older age. So for example, about 2% of people in a similar age group as CLL, patients with CLL tend to be about 4% of patients, and in the ibrutinib trials was about 10 to 15%. So what are some of the risks of atrial fibrillation? Well, with or without having CLL, it means meeting with a cardiologist to make sure the heart rate is controlled and to see if you need a blood thinner, because that funny beating of the heart can sometimes make the blood not flow right through the heart, and people are on a BTK inhibitor. Sometimes patients, if they develop this on a BTK inhibitor, such as ibrutinib or acalabrutinib, continue the medicine. But again, it's really important to talk to your team, because if you're starting new medicines, they may interact with the ibrutinib or acalabrutinib. If you have other options, it might be helpful to stop treatment or switch. And because of the blood thinner and BTK inhibitors have a higher risk of bleeding, it's just understanding what the increased risk for bleeding is. So just want to highlight all that there. Now moving to bleeding. So about half of patients have easy bruising with BTK inhibitors, but severe or major bleeding, depending on the study, can be anywhere from 4 to 6%. And that's because BTK which is the target in the leukemia cells, are also in platelets. So ibrutinib or acalabrutinib, almost similar to how aspirin makes the platelets not as sticky and functional, so can ibrutinib or acalabrutinib. So there are important things to consider. It doesn't mean you can't be on a blood thinner if you need to, but your risk of bleeding is a little higher. I strongly am against the patients being on Coumadin or warfarin plus a BTK inhibitor, because in the studies that had a much higher risk of bleeding. But there are other types of blood thinners that sometimes that's still the right option for patient. But then importantly, if you have a planned surgery or procedure and you're on ibrutinib or acalabrutinib, it's important to talk to your health team about that, because for minor surgeries or procedures, you hold the medicine 3 days before or after. For major, it's about 7 days. I mentioned the muscle and joint aches, which is one of the common side effects. I've had patients that just get to know their body. We check for and what works best for them. We check for electrolytes to make sure they're all corrected. But again, in some patients, they're manageable. In some patients, we have to interrupt or lower the dose. With acalabrutinib, just want to mention, because unlike ibrutinib, acalabrutinib, as well as in the trials, zanubrutinib, can have headaches, usually in the first couple of weeks of starting treatment. And for patients that can also handle caffeine and Tylenol or acetaminophen seem to help this. I try to avoid medicines that can affect how the platelets function, such as ibuprofen, but most patients can improve that, or the headaches improve with time and seem to just go away on their own. We already went over for Venetoclax some of the side effects, such as the tumor lysis, and the importance of that monitoring, and then not only in classifying individuals' risk for tumor lysis, but ways to lower that as well. For GI or diarrhea or loose stool side effects, this can happen with the BTK inhibitors and Venetoclax. I think it's really helpful when someone says they have diarrhea. The things I ask about is, we expect sometimes a lot of times there'd be a difference from what your baseline stool habits might be, but some changes on medicines can be managed. But clearly, if people are having a lot of watery diarrhea symptoms or the frequency, then that needs to be obviously addressed sooner rather than later. But keeping a diary of the symptoms and what might trigger it. For example, if these medicines make things move through the bowels faster, certain foods or drinks might exacerbate that more than others. But keeping track of the frequency and what might trigger it is really important. I'm going to move on and not go over the toxicities. PI3 kinase inhibitors are not yet approved for the first treatment of CLL. So you'll hear more about these in the managing of side effects for those patients with relapse or refractory CLL. So in the very last part, I just want to highlight, there was recently a study, and this is again something near and dear to us in our clinic, as we're trying to have studies for patients that are focusing on what we call chronic cancer care, recognizing, hopefully, as we keep the CLL stable or under check, that patients can continue to focus on other aspects of their health. And in this recent study, just showing while causes of patients passing away or dying, certainly if it's a higher risk or aggressive CLL happen, a lot of patients are passing away or dying of other causes, and how we prevent them is really important. So for example, cardiovascular disease, renal dysfunction, or other causes. And how do we get to that? How do we address all this that's not directly related to the CLL? And I think this more and more post-pandemic calls on us pulling in primary care and other oncology-specific clinicians, such as cardiologists interested in risk prevention, and renal doctors or kidney doctors in this, as well as how do we know what patients' risks are, and how do we integrate making sure patients have all the vaccinations they need, have all the cancer screenings they need, and how to modify risk factors. Because again, our goal is obviously on the CLL, We want patients living long and healthy lives for a variety of reasons, especially if it's things that are being unintentionally overlooked because of their CLL diagnosis. We want people to live with this and hopefully not be the focus of all of things. So with that, hopefully we've left enough time here for questions. I'd be happy to answer. And once more, just want to thank you, not just for the invitation to present today, but for all of you in knowing or being part of participating, especially in clinical trials or clinical studies to help patients with CLL and SLL.
Well, thank you so much, Dr. Brander, for a wonderful presentation. We'll now begin our Q&A portion of the program. Just as a reminder, please keep your questions general in nature. And if you'd like to ask a question, please submit it through the Q&A button at the bottom of your screen. Get as many questions as possible, but if a question cannot be answered, then please feel free to reach out to our helpline at 800-500-9976. So our first question is, since many CLL patients are older, how well do they tolerate the newer treatments such as CAR-T and other novel therapies?
Excellent question. So if you start just kind of very basic, the first BTK inhibitor, targeted BTK inhibitor that was approved, as those studies get longer and longer since patients first went on those studies, we know in clinical trials, older patients, while I have many patients that tolerate ibrutinib or the newer inhibitors, certainly age is one of the risk factors for less tolerance. I would say, though, less and less is age such a big factor in determining treatment options or choices. Not that many years ago, with only chemotherapy, there really was an age cutoff where we knew older patients weren't going to tolerate that. So overall, the tolerability, I say, is much better, especially as we get to newer inhibitors. There might be other health conditions, though, that go with, it's faster to say older, but I prefer, honestly, to say more experienced in life. But anyway, older patients are more likely to have other health conditions, such as their kidneys not working as well, their heart, maybe other heart conditions, and that can affect a higher likelihood of developing side effects on treatment. Or, for example, with Venetoclax, if the kidneys aren't working as well, can be a higher risk of tumor lysis. So for those type of therapies, the answer is I more come across patients who are older that might not tolerate as well as younger patients. However, it's not as absolute of a risk for not tolerating as it was with chemotherapy. I think part of that is, what are the things we can identify and lower the risk before patients start? For example, as patients are older and on more medicines, can we identify medicines that might interact or have similar side effects so that we address all that before people get started? Because I think one of the advantages in getting started on these treatments is it's very rarely that we don't have some kind of warning that people are about to need treatment or have a couple weeks or a month till you have to start with treatment. It's not you have to start the next day. So if I see medicines that people are on or other health conditions, I'll reach out to their primary care or their cardiologist. How can we lower the risk? Knowing what to expect in the side effects. For example, with the loose stool or diarrhea, if it's really not being well tolerated and we can't find a trigger, as long as there's no evidence of infection, we can use medicines to slow down the gut and lessen the diarrhea. So I think an open dialogue. I know part of that question beyond the targeted agents was about CAR-T, and right now CAR-T for CLL is still only within clinical trials, while CAR-T has been approved for a number of lymphomas, which has been remarkable. For CLL, there are still a lot of studies of how do we optimize it. Again, age is not an absolute cutoff, I think, in general for cellular treatments, but in many of the clinical trials, understandably, when you're testing a drug, sometimes age is an absolute cutoff. But I have had patients, we have all had patients in clinical trials. I guess it depends what you call older, that still can be managed through the CAR T side effects or the CAR T symptoms. And then lastly, you'll hear about, again, in the session for patients where the CLL has come back, relapse or refractory CLL, about some of these next generation inhibitors that aren't yet approved, that are becoming more selective. And a lot of times these more selective drugs, if they look like they work the same, more selectivity usually means less side effects. So I think we're going to see for older patients, or for all patients, that some of these next generation inhibitors will be even better tolerated.
Thank you. What is the operational definition for patients?
What is the
Operational definition of older patients?
Oh, yes. Okay. Great question. So in CLL, SLL, historically, trials have used a cutoff of age 70. So in a lot of the trials that historically said for older patients, it was either 65, but more commonly 70. That was with chemotherapy. But that was based on age. There are other, not just for CLL, but within different cancers, ways that people are trying to incorporate age as one factor, but comorbidities or other medical side effects to better operationally say, what are people's comorbidity risks, their age, but also, you know, a 72-year-old that has few medicines and maybe only elevated blood pressure, we know is very different than, say, a 60-year-old patient who has problems with their kidneys and their lungs and is on 7 different medications. So, but most commonly trials used an age cutoff of either 65 or more commonly 70. More and more people are trying to either pick an age and or say comorbidity or other health problem index. So you'll see in some of the trials, it'll say CIRS, CIRS is a way to kind of weight together and look through all the different medical problems a patient might have, recognizing that is just as, or if not more important than just an age cutoff. Thank you.
The next question is, can you speak more about side effects? I know you mentioned that near the end of your talk. What cause people to go off of treatment?
Yeah, so it depends on obviously the medicine. So I'll just say for BTK inhibitors, Bruton's tyrosine, that's ibrutinib and acala are the two that are approved. While if you look at a lot of the studies, often one of the most common for ibrutinib was myalgias or arthralgias. So it's not necessarily a high grade, but with time becomes one of the high burdens. But there also can be other side effects. For example, now, you know, atrial fibrillation, or people are in the hospital with other heart arrhythmias, might not happen commonly, but might likely be a side effect more and more that you don't want to restart the medicine. That's for BTK inhibitors. For Venetoclax, because as first treatment, it's for fixed duration or 1 year, there's not as much in that first year discontinuation for day-to-day side effects that the patient feels, but GI side effects are one of the more common things, nausea or diarrhea, or patients might feel fine, but if they fall in the category more in the relapse refractory setting of recurrent low blood counts, that might be a reason to have to stop. There's a lot of good, I think, because it would be hard, like I honestly in clinic spend probably 20 to 30 minutes myself, plus the clinical pharmacist, plus the nurse, or APP with a patient, that I would refer either through the LRF, the NCCN. Many have patient-specific guidelines for the specific medicine. And the two things I think that's helpful to ask your team are what to expect, what are the most common side effects, even if it's not going to lead to stopping treatment, and what are the uncommon ones, but they're the major ones that I have to look out for that might lead to stopping.
Thank you. And we have time for one final question. Do you know of any connection between melanoma and CLL, more common in CLL?
So not as very broadly, non-melanoma skin cancers do appear more commonly. And so in that whole kind of preventative health part that I try to go over with patients is the importance of seeing a dermatologist at least annually, even if you don't have a history of skin cancers. For reasons we don't fully know, but maybe because the immune system doesn't work as well, there is a higher incidence of skin cancers, usually not melanoma, but other types of skin cancers are more common than melanoma, so might be why we don't see the difference. And I'll just say there's a general lack of data, but we're trying to understand how other cancers such as colon cancer or melanoma or lung cancers, how do we make sure patients are getting the screenings that they need?
Thank you, Dr. Brander, for your time and expertise. Before we conclude this session, I wanted to highlight that next on our agenda is a 15-minute break, just to stretch or visit our networking lounge. Then we'll reconvene at 2 p.m. Eastern Standard Time for our next session on patients and physicians panel discussion. So thank you again, Dr. Brander, and for all of you for joining us today.
Thank you all very much.